So as an organisation, appointing a Chief Information Officer means that the organisation is taking seriously the impact technology can make on delivering healthcare. Creating a role and creating an office of the CIO within the HSE gives it a sense of responsibility, puts a governance structure in place and allows us to drive forward considering benefits, considering how we work, how technology can have an impact on healthcare across the whole of Ireland. I think the fact that there hasn't been a CIO previously within the HSE simply is just a time period of accepting how technology can help healthcare. I think the change in investment and the change in attitudes towards technology globally, not just in Ireland, and the impact it can have on patient care. Putting patients at the centre, empowering patients, the consumerisation, as we call it, of IT, where people expect technology to help them and therefore expect it in healthcare, means that the changes come now at the right time as lessons have been learnt globally, and how a Chief Information Officer, a role that actually embodies change and benefit-led impact on healthcare, can really bring a difference to what's delivered. The digital revolution in healthcare it's not just a buzzword. I don't think so anyway. I think the digital revolution in healthcare is adapting and seeing how technology has helped so many other areas. You wouldn't walk into your bank and assume that you could just say your name and get access to your cash. So why would you walk into healthcare and just assume that they would have access to all that information using paper? So when you look at your everyday life and how much of an impact technology has had on your everyday life now, it's time for it to have an impact on healthcare in every country across the globe. The impact it has on the patient will be to make their healthcare more efficient, give them access to information themselves, enable a patient to stay well. One of the things we talk about a lot in a digital revolution in healthcare is actually empowering the citizen to stay well, rather than concentrating on information and technology to make the patient better. A clinician in the world of a digital revolution within healthcare has the tools and the capability to deliver a more efficient, a more safe, a more patient-focused care delivery scenarios. And that makes it easier to do their job, makes it better for the patient and easier for them to be able to provide the care they want to do. Globally, there are some really good examples of e-health being implemented into the healthcare system and the impact that can make. All of those countries have taken periods of time, up to 10 years, to actually be able to have an impact using technology on healthcare. If you look at New Zealand and Australia, they have digital hospitals, they have the ability for healthcare records to be available to the clinician, to the patient, to the healthcare system. If you look at Canada, they're using clinical records anonymised in clinical research with patients' permission and moving forward quite quickly in how healthcare is delivered and how that can support the clinical research journey. Obviously, I'm from the UK, and I would mention the UK's National Programme for IT. Initially, it was a bumpy ride, it was a difficult process, but now you see 60 million patient records that are summarised and available in emergency department. That means that a patient that turns up at an emergency department with an adverse reaction to a drug, the clinician knows what that adverse reaction is. One of the things I've focused on a lot since getting here, though, is that we don't think that Ireland has got any centres of excellence, and yet we have e-referrals piloted in 2 major areas of Ireland hugely successfully. In 3 hospitals, we have technology beyond any of those 3 countries I mentioned, where they can actually use the RFID tag on a patient's wrist to actually analyse where their blood samples and test results are. 2 massive examples of huge innovation that in other countries have taken hundreds of millions of pounds, hundreds of people to implement. In Ireland have been done as pockets of absolute innovation excellence. One of the things I want to do through eHealth Ireland is actually take those pockets and turn them into countrywide solutions. So we've taken the excellent work through e-referrals in Cork and Kerry and have committed to actually turn that into a programme through 2015 where phase 1 of e-referrals will be available across the whole of Ireland. Because the country, the people, the clinicians, the patients of Ireland have proven that that works, that's a benefit, and that delivers excellence for them. So e-referrals in Cork and Kerry, the pilot that's happened there, as far as phase 1, is about taking the referral letter process that previously was about the GP deciding that they needed to refer a patient, writing a letter, putting it in the post and sending it to the hospital. Now within the GP system, they generate an electronic e-referral letter. They send that to the hospital, who have a triage centre so they can take those e-referrals and understand what they need to do with them across the hospital. Now, phase 1 is very much about making electronic the passage of e-referrals out of the GP practice and into the hospital. It's not about integrating that straight into the hospital system. But that brings big benefit because it removes the need to post a letter. It removes the hands that would touch the letter and have to look at the letter and pass it through the system. And it also means that when the patient leaves the GP surgery, they know their referral has gone to the hospital. So that in itself is an amazing leap forward. The tags in hospital that I mentioned previously is very much about allowing the identity of the patient to be linked to inside the hospital, their blood results, their blood samples that are being taken. So regardless of which clinician comes to talk to them, they can access the information and know the results that have been taken previously, which avoids additional tests, which avoids additional stress on the patient. Ireland has developed these small ecosystems of excellence, but the infrastructure has needed investment for some time. E-health is an expensive, IT isn't free, and I think we're fond of sort of pointing out the cost of IT in the industry, but IT isn't free. One of the areas that we need to look at is the sheer number of systems that are deployed and how they don't talk to each other. So one of my core priorities for 2015, first part of 2016, is to start to put indexing systems and integration capability into those systems. That's why the individual health identifier is so important to us. We can't have a linking of systems unless you can identify patients across different systems as they exist. The individual health identifier is an index to enable systems to identify a patient when they're in more than one system. And that's probably the easiest way to think about it, is it's like an index number. It's not a number that equates to the provision of healthcare. It's not got any medical records or electronic health information associated to it. It's simply an index that makes sure that when Richard Corbridge walks into that GP and is given that drug, when he walks into the A&E department, they can identify that it's the same Richard Corbridge across those different areas. And that's really important once you start to integrate care and once you start to integrate healthcare systems using technology. Because you need to make sure that you're always talking about the same person. It's not a bank account number. It's very much a system index number that makes sure that it's the right person that we're talking about and how that's done. The process of making those live and the timelines for those very much has been said already by the Minister. In this year, the IHI will be available. Initially, it will be an index that we can do downloads from, we can pass information to other systems, and then in the latter part of the year, it will start to be exposed in the clinical systems that have appropriate context for doing that. The benefits of an individual health identifier are very much about having the ability to exist in multiple systems and always be referencing the same person. So if there is information about me in one hospital and there is a legitimate relationship and reason for a clinician to know that information in a different hospital or in a different care setting, they need to know that it's the same person they're talking about. Or if you take the e-referral example I gave earlier, if the e-referral is leaving the GP and arrives electronically in the hospital, they need to be absolutely sure that when they link that referral to my record in the hospital, it's me they've linked that record to. So this is very much about making sure that there is a connection across the different care settings and across the different IT systems that support care throughout the HSE and throughout Ireland. The individual health identifier and security or concerns around privacy. As we've said, it is an index. It's the ability to find out that you are who you say you are from system to system. So it's very much to be considered as a system identifier. That's the first point to make. Second thing is, whilst it isn't necessary for patients to have their IHI, their individual health identifier, they can ask for it, they can have what's in that record, what's in that system. It will be their name, their date of birth, their address, their demographic information only. So it isn't information that would reveal anything clinically about a patient at all. It is simply an identifier from system to system. Having said that, however, it will only be the clinicians with a legitimate reason to access those systems that will be seeing the IHI as well, to make sure that from the first thing we do through eHealth Ireland is as secure and starts to build the confidence of patients as we start to digitise the healthcare system. So the first thing we do is create the IHI on a central database so that it's there and can be pulled down into different systems. We will then work with the GP system suppliers to expose that into their system. The decision about which system to make it available in next is a clinical decision, and that will be based on the capacity of that clinical care setting, be it, let's call it the hospital PAS for now, the administration system. It'll be a conversation with the hospital about the clinical input as to where that IHI should go, who should be involved in the decision making about how it's used and how it's implemented into that system. Each care setting will be taken on a benefits-led basis to make sure that there is a reason for doing this. It isn't just about putting it in there so that it's an administrative tool. It's not. It's very much prime reason for being here is actually to do with patient safety and managing them to make sure that information is correct about each patient. Individual Health Identifier does what it says. It identifies the patient. You can't have money follows the patient if you can't identify the patient. So the IHI is a precursor to money follows the patient. If we want to be able to say where money is being spent on healthcare across the population, we need to be able to identify the patient and to make sure that the patient is getting the right levels of care, the right information is recorded about them, and that we can manage the healthcare system efficiently and, most importantly, safely. We need the IHI to be in place. So the concept of an electronic health record is a huge concept, particularly if you're looking at a country-wide solution. What we're doing as an organisation is understanding the strategy for delivering an electronic health record. One of the lessons learned, and a key lesson learned from other countries, is to not go at this trying to deliver one solution for every care setting, one size fits all. When it comes to electronic health record for Ireland, we're looking at a system that integrates to other systems. So we will have a core set of information that we will call the Ireland EHR, the Ireland Electronic Health Record. That doesn't preclude or stop other organisations or therapeutic areas putting in place electronic patient records. The caveat to that is twofold though. An electronic patient record that is, say, specific to cancer must have the IHI in it and must integrate to the electronic health record for Ireland. The first organisation which will actually adopt the electronic health record as its core system will be the National Children's Hospital when that opens. And our strategy and our plans and our business development is all towards making sure that when the National Children's Hospital is open, the system is there and ready for them to use. If you think about being able to move from hospital to hospital or care setting to care setting or ward to ward and not be asked the same questions, not have the same tests done. For me, an electronic healthcare system is about not just the efficiency that it brings, but the safety and the comfort and ability for the patient to take part in their healthcare themselves. If we can make an electronic health record available to a patient, for example, that they can access and see and understand, then they can make some choices about their own healthcare provision, their own healthcare settings. One of the things we've seen in other countries where they have adopted the EHR is concerns about privacy. And again, because of the timescales that we're implementing, we're able to learn lessons from those areas. We need to make privacy a number one important piece that needs to be resolved. We need to ensure that electronic health records are accessed only when it's legitimate to do so and by clinicians with an appropriate relationship to the patient. And technology is there and able to facilitate us doing that. We need to be able to audit who has accessed an electronic health record and understand the reasons why they've done that. We need to be able to secure the electronic health records when they're at rest, shall we call it, so that actually we know that the data itself is safe and secure in where it is. And they're really big cornerstones of what we do as we start to design what the electronic health record would look like, what would be in it on day one, and the systems that we'd look to procure to put that out there. Privacy concerns around an EHR are often about my friend, my neighbour, my family member being able to access an electronic health record. I think one of the things we have to be aware of, though, is the person has to have a legitimate relationship to do that. It is part of their caregiving function as an employee of a healthcare service to only access information about you where it's appropriate for them to do so, where they need to do so for delivering care. Today, if somebody wanted to look at your paper record and see something about you without a legitimate reason to do so, they could. With an electronic health record, they have to be audited that they have accessed that information. They have to be able to say they've had a legitimate relationship, and the system will know who has looked at electronic health records. So it becomes easier to control where electronic health records are being viewed and understand how and where they're being viewed. I think in other countries where the EHR has been put in place, there has been consent given or opt-out, opt-in, and it's been a debate that has raged shall we say, in other countries and caused delays to delivery. My own personal view is if you ask patients to opt in, only those that are involved in care now will opt in, and then how do you capture the one that didn't see the letter and come forward and opt in? And also the overhead of asking people to opt in to have an electronic health record is significant. If we are sure that we have the right security and privacy guidelines in place, and I think it should be possible to opt out and assumed consent for having an electronic health record. In doing that, though, a patient that opts out of having an EHR must be really clear in what they're opting out of having. And I think the healthcare system still also needs to be really clear on that it is providing healthcare to that patient and needs to still be able to provide a quality of healthcare to that patient. And that becomes more difficult as time progresses and the clinical setting relies more and more on the digital healthcare setting as a way of providing care. So we need to test the water and tread ever so carefully and ever so slowly, understanding what patients want and what clinicians want in that space before we leap one way or the other. But there's a lot of lessons again that have been learnt that we can get at and use. So the team that is delivering eHealth Ireland is currently the HSE's old IT team, which is now considered to be the office of the CIO. And that's a team of people that are scattered all over the country, working in hospitals, working in HSE settings, delivering a number of different areas, ranging from infrastructure, so the real typical sort of technology-based solutions, through to analysts, through to people looking at business type and change and how we manage that, making sure that as we deliver benefits we understand what they are. So it's a really crucial time for the resource. What we've done, or what we're doing rather, is putting in place a structure that allows us to mirror the new HSE structures, so around hospital groups and community care settings, and making sure that actually where IT is provided as a solution to change, it's seen as very much mirroring the HSE settings that are there now. In 2015, the funding we have to deliver the technology solutions that we are planning in this year has increased and is adequate to deliver what we plan to do in 2015. To move to an EHR will require a business case, which will describe the total funding needed, the total resource needed. To deliver an EHR for the whole of Ireland will take more people and will take additional funding to do that. It takes that because it is about engaging clinicians. Clinicians need to be involved in the changes that we're making as we deliver the solution. So you can imagine that you wouldn't buy a car without going and sitting in it and understanding what it could do and then the specification of that. We need clinicians engaged to be able to do that, and that will cost money to take them out of the care setting, to look at the systems, test them, make sure we're getting the right one, help design to make sure that it's fit for purpose on day one. Which again is another lesson from other countries where clinicians have been less involved in the purchasing of an EHR. On day one it goes live and the clinician goes, well, I can't use that. And we need to make sure that we don't make that mistake and we get that right. The numbers of people across the team, across my team that are delivering this system, again in 15 is a good number of people to deliver the system, is an adequate number. But as we roll more of the strategic programs up and start to put those in place, there will be a need for additional resource. One of the biggest lessons that I bring from working on the National Programme for IT is that I need to engage clinicians from the beginning. We put the patient at the centre of the eHealth Ireland strategy, and we put the clinician at the centre of what we're trying to deliver. By doing that, I want to engage and have support of the patient and the clinician from the very beginning. As I said earlier though, one of the other elements that I believe in from a personal point of view is this isn't just about patients who are ill. This is about citizens, this is people who live in Ireland, and how we enable them to stay well as well through technology and healthcare that's supported by technology. So I'm trying to make sure that this organisation that becomes eHealth Ireland absolutely has those two principles at its core. It's not about technology and wires and tin. It becomes about the benefits, the return that people expect from healthcare. It's about making sure that the outcome that a patient wants or a clinician wants is supported by technology to deliver it, not focused on technology as a way of changing it.